This lecture will be the first half of the material covering respiratory or pulmonary physiology, and we'll be focusing on the ventilation of the lungs, that is, the exchange of gas into and out of the lungs. Let's take a look, first of all, what we mean by the term respiration. Respiration has two meanings. One is internal respiration, in which case what we're actually talking about is metabolism, as we have here in the diagram, a metabolically active cell. This is the mitochondrion here. And we have, of course, consumption of oxygen and production of CO2 during the metabolic process. So this is internal respiration. And it's another word or term that is used to refer to oxidative phosphorylation, which, of course, is the production of ATP within the mitochondria. What we're going to be interested in this section of the course is external respiration, that is the act of breathing. This is pulmonary ventilation, that is the movement of air into and out of the lungs, and of course the exchange of gases between the lungs and the blood. And the transport of oxygen as well as CO2 in the blood, and then again the exchange of these gases between the blood and the body tissues. So we have the exchange occurring in the lungs, as well as exchange occurring within the tissues. Now, this exchange occurring with the tissues is, of course, complementary to what's going on here in terms of internal respiration. That within this particular diagram, the internal respiration is what's happening within the mitochondrion, that is the true metabolism, which, of course, has to work hand in hand with the external respiration, which is the provision of oxygen to the mitochondria, as well as the uptake of CO2 away from the mitochondria. So the two of them complement each other. But internal respiration, that is metabolism, of course, is not possible without external respiration. And as I said, external respiration is synonymous with pulmonary ventilation, which will be the main theme of this lecture. So we're going to have to look a little bit at the functional aspect of the anatomy of the respiratory tract. And we'll need to switch back and forth between slides 3 and 4 here. So let's go back to slide 3 first of all. The conducting zone of the airway. Well, as the name suggests, it conducts air into and out of the lungs. So the conducting zone is that part of the airways that starts at the nose and mouth, goes down through the trachea, the bronchi, all of the different airway branches that we have here going off into the lungs. And this is the conduction of air into and out of the lungs, hence the name conducting zone. And the function, of course, is to conduct gas to and from the respiratory zone. The respiratory zone is the lower part of the respiratory tract that we've shown as a sort of an outset here, where the bronchioles are terminating in these what are called the alveolar sacs, or the alveoli. Those two terms are used synonymously. Some people use the more basic term gas sacs, but this is where the actual exchange of gases is going on that we refer to in terms of external respiration. So as I said, the function of the conducting zone is to conduct gas to and from the respiratory zone. In the process of doing that, it warms the inspired air. The inspired air needs to be brought up to body temperature, as well as humidifies this inspired gas or air mixture, bringing it up to fully saturated with water vapor that is 100% humidity. In addition, the conducting zone serves as a protective function, what's called the mucociliary escalator. That is, there is a mucous membrane lining the airways, and it is ciliated epithelium. And that any particles that get inhaled get trapped in the mucus and then carried up by the ciliary action up toward the mouth, where it is ultimately swallowed. So, of course, it serves a protective function as well. The conducting zone consists of the trachea, the bronchi, and the secondary bronchi. On the right side, there are 3 lobes on the right lung, and 2 lobes on the left lung and the secondary bronchi, as shown in this diagram here, keep branching over and over again to provide subsequent what we call generations of the bronchi going down to bronchioles ultimately. So the respiratory zone, the function is gas exchange. Gas exchange occurs by diffusion. That is, of course, as blood coming back from the metabolically active tissue coming into the right heart of the lung, that is the blood coming into the right heart of the lung, it has been depleted of oxygen and has a higher CO2 content. And, of course, oxygen diffuses down its concentration gradient from the alveolar gas into the blood gas. And CO2 diffuses from the blood gas into the alveolar gas. We'll talk about those ideas in more detail later. Respiratory zone consists of the respiratory bronchioles, which are several branch points away from the secondary bronchi we've talked about before, the alveolar ducts, the alveoli, and the alveolar sacs. So we're just showing diagrammatically what we've talked about on the previous slide. The upper airways and lower airways, what's called the respiratory tract here, is all the conducting zone, and the alveoli, the terminal bronchioles, respiratory bronchioles, basically the very end of the airways themselves, which end up terminating in the in the alveoli, constitute the respiratory zone. So let's take a little bit more detailed look at the anatomy of the respiratory zone. So we have the structures in the respiratory zone that we've seen in the previous slide. And of course, as I said, the alveoli is the site of gas exchange between the blood and the inspired gas. We have about 300 million alveoli in the lung, and together their surface area is about that same surface area as of a tennis court. So it's a very large surface area that is then condensed into the lung. It's a very rich blood supply. So here we show these alveoli. Of course, they look like a bunch of grapes. That's the typical way of describing them. But let's look at an individual one. So this is the alveolar wall here. And as you can see, it is surrounded by numerous capillaries. And the capillaries, of course, are bringing this rich blood supply, taking blood that's coming in from the right side of the heart. So the blood has low oxygen, high CO2, and the capillaries are so densely packed around the alveoli, it's as if there's a continuous sheet of blood that's just bathing the alveolar surface. Of course, it's not that way, but it's similar to it in terms of similar to a sheet of flow. Within the alveoli, we have different cell types. There are type 1 alveolar cells that make up the alveolar wall. These are most of the cells that you see along here. And these make up the wall of the alveolar wall of the alveoli. They're a single layer of epithelial cells. And then type 2 alveolar cells. These synthesize and secrete a substance called surfactant. And this is one that's shown here in the diagram. I realize that these illustrations are a little small to see on your screen, but I encourage you to look along in your textbook so that you can see more detail. And surfactant increases the compliance of the alveoli. We'll be talking about the topic of compliance later, but for now, keep in mind the idea that it means that the compliance means ease of distensibility. That is, how easily the alveoli can be stretched open, how easily they can expand to receive fresh air. Higher compliance means that the alveoli can actually expand much more easily, and surfactant helps to increase this. We'll talk about why a little later on. In addition, there are alveolar macrophages, which, of course, as we just learned in the immune system, macrophages are responsible for immune functions. Now, one of the things you need to keep in mind here is when we take a look at a cross-section of the alveolar wall, is that it's incredibly thin. That here we have the blood plasma with red blood cells, of course, in the mix. There is the capillary endothelium, which is just a one cell layer thick, the alveolar epithelium, and just a very small area here of interstitial space. So there's very, very little barrier for exchange between the alveolar gas and the plasma and the blood. And of course, in disease, we can have thickening of these membranes due to scarring, as well as there can be fluid accumulation in the interstitial space. So this, of course, can become a much larger volume and a much wider separation in the barrier here than what is shown in this particular diagram, at least during disease states. And this structure we refer to as the respiratory membrane. It acts as a barrier for diffusion. Now, of course, in a normal healthy lung, the barrier is minimal, but it nevertheless does represent a very real obstacle for the movement of gas molecules from one side to the other side. And what I'm showing here going in this direction, of course, would be oxygen, and conversely, CO2 would be diffusing in the opposite direction. And as we've said before, the type 1 cells represent the alveolar epithelium, and there's a little bit of basement membrane, and then we also have the capillary endothelial cells and its basement membrane. But those are just one cell layer thick, so this is actually a very, very small space with regard to the total volume of an alveolus. And again, the interstitial space. The total thickness is about 0.2 of a micron, that is 0.002 of a thousandth of a millimeter. So that's very, very thin indeed. Now, in order to get air into and out of the lung, we have to have changes in pressure. As I've mentioned in previous lectures, that one of the main things that you have to understand in all of physiology is that there are gradients that cause the movement of substances. And these are either concentration gradients or pressure gradients. And in this case, it's a pressure gradient. That is, you inhale, you're actually having air move from a higher pressure outside of the body to lower pressure area inside the alveolus. And of course, when you exhale, you reverse that pressure gradient. So air moves in and out of the lungs by bulk flow. And it's the pressure gradient that drives this flow. So air moves from high pressure to low pressure. As we inhale, that is, as we expand the lung volume, we create an area of low pressure within the alveoli. And air then moves from the higher atmospheric pressure down into the lower pressure within the alveolus. So during inspiration, the pressure in the lungs, that is in the alveoli, is less than atmospheric pressure. And during expiration, the pressure in the lungs, that is in the alveoli, is greater than atmospheric pressure. I have to look at some terminology here as well as their standard abbreviations. Throughout, we use a capital P, at least throughout pulmonary physiology. We use a capital P to refer to pressures. Atmospheric pressure is, of course, the same pressure that the weatherman refers to, the barometric pressure. But from a physiological standpoint, this is quite often referred to as zero, since it is the reference pressure. It is, of course, not truly zero pressure, because generally atmospheric pressure is about 760 millimeters of mercury. So it's a substantial pressure, but because it's the reference pressure outside the body, it is generally referred to as zero. The intraalveolar pressure, that is the air pressure within the alveoli themselves. Now, the lungs are surrounded by a very small space that's called the pleural space. So the pressure within this within this pleural space is referred to as the intrapleural pressure. And as I said, this is the pressure inside the pleural sac, which surrounds the lungs. And the other wall of the pleural sac, of course, lines the chest wall cavity. And this intrapleural pressure is the pressure within that cavity. Transpulmonary pressure is really the most important of all. This is the pressure across the lung wall. So it is alveolar pressure minus intrapleural pressure. It is the distending pressure across the lung wall, meaning it is the pressure that exists across the alveolar wall, and it is, of course, the net result of these other pressures that we've talked about. And ultimately, this is the pressure gradient, the driving pressure, that causes inflation or deflation of the lungs. So let's take a look at this a little bit more. As we have here, I have to change my pen color again. We have the outer layer of the lung, and then the inner layer of the chest wall, Now, because of the scale of this diagram, my lines are running into each other, but in between those two, there is a fairly small space. Now, this is shown diagrammatically here. This is the outer wall of the lung, and this is the inner wall or inner surface of the chest wall. This space is referred to here as the pleural sac, is this very small, very thin space that is filled with fluid. And this is the space where the intrapleural pressure is exerting itself. Now, the lung and the chest wall are both very elastic. The lung is even more elastic than the chest wall, of course, because the chest wall has ribs in it, which tend to give it a certain amount of rigidity, but it still has some elasticity. The lung basically behaves like a balloon, so it has a fair amount of elastic recoil. The lung, when it's stretched open, which of course it's always open, it never fully collapses, the lung wants to recoil back. It wants to decrease its volume. But because this pleural space is filled with fluid, there is what's called a capillary force. It's the same sort of force that pulls moisture up in a capillary tube in a lab or pulls it up in the stalk of a plant. And this fluid-filled space basically functionally attaches the outer surface of the lung to the inner surface of the chest wall. And this means, of course, since there's an inward elastic recoil of the lung, it's pulling the chest wall inward, which means that there is an outward elastic recoil that's trying to exert itself of the chest wall. So the chest wall is pulling the lung out, but the lung is pulling the chest wall in, which causes this sort of dynamic to set up, which is why we have a negative intrapleural pressure, because we have forces acting on either side of the pleural space trying to pull it open more than it is. And this causes this negative intrapleural pressure. And it basically is largely what helps to keep the lung or the alveoli open, as well as contributes to the pressure gradients that move air into and out of the lung. So I've mentioned before atmospheric pressure. At sea level, it's 760 millimeters of mercury. Now, of course, this depends upon weather, etc. But as from a physiological standpoint, we assume it's fairly constant at 760 millimeters of mercury. This pressure, of course, decreases as altitude increases. So as you climb up mountains, if you drive, let's say, to Denver, Colorado, or some other mountainous area, that the atmospheric pressure decreases because there is a thinner atmosphere. That is because of the gravitational effect of molecules in the atmospheric gas. When you're higher up in elevation, there are fewer gas molecules above you. Therefore, there is a lower atmospheric pressure. And, of course, the pressure increases underwater because of the weight of water. Other lung pressures are all given in reference to or relative to atmospheric pressure. And as I said, in physiology, most sources, although I've seen a few books that actually give it in actual pressure, but most sources just refer to it as 0 millimeters of mercury, since it is the reference pressure against which all other lung pressures are compared. So intraalveolar pressure is the pressure of the air in the alveoli, and it is given relative to atmospheric pressure. Of course, it's going to vary with phases of respiration. During inspiration, it's going to become negative. The alveolar pressure needs to be less than atmospheric pressure in order to allow air to enter the lung during inspiration. During expiration, intraalveolar pressure or alveolar pressure, both terms are used, is positive. That is, it's greater than atmospheric pressure, which of course makes sense. You need the pressure within the alveoli to be greater than the atmosphere in order for expiration to occur. So intraalveolar pressure is the difference between the alveolar pressure and the atmospheric pressure, and this is what drives ventilation. Intrapleural pressure is the pressure inside the pleural sac. It's always negative under normal conditions, and that's because of the outward elastic recoil of the chest wall and the inward elastic recoil of the lung. That means it's always less than alveolar pressure as well. It varies during the phase of respiration, at rest, that is at the end of expiration. So rest is end of expiration. It is about -4 millimeters of mercury. And this is, again, because we have the elastic recoil of the lung and the chest wall opposing each other, creating, if you will, a vacuum in between. A vacuum, of course, is when pressure is less than zero. So this negative pressure, as I said, is due to the elasticity in the lungs as well as the chest wall. The lungs have an elastic recoil that is directed inward. The chest wall has an elastic recoil that is directed outward. And these opposing forces, these opposing poles, act on the interpleural space and create this negative pressure. There is also surface tension of intrapleural fluid that exists in this pleural sac. So this intrapleural fluid we're talking about is filling the space between the two pleural membranes, and it is basically holding or gluing the two pleural surfaces together so that they function as if they were actually attached. But there is, of course, a pressure within that space. The transpulmonary pressure, as the name suggests, is the pressure across the lung, across the alveoli. So it is calculated as taking alveolar pressure and subtracting intrapleural pressure. It is the distending pressure across the lung wall, it's the pressure that is keeping the alveoli open. And of course, transpulmonary pressure increases as we inspire, as we expand the chest wall, we pull the pleural space outward even more, which is going to increase the distending pressure across the lung. That is, the amount of pressure across the alveolar wall will increase, which expands the alveoli and allows the alveolar pressure to decrease and therefore air to flow in from the atmosphere. So as the lungs expand, the alveolar volume increases, which decreases alveolar pressure. And of course, if alveolar pressure decreases, then air from the atmosphere is going to rush in and fill that alveolar space. If the functional attachment we've talked about before in the alveolar space is disrupted, it's called a pneumothorax. And as an example here, if there were to be let's say, in trauma, a bullet wound, stab wound, whatever, that goes in through the chest wall, of course, because there is an inward recoil of the lung will collapse. And because this inward recoil of the lung is helping to pull the chest wall in, the chest wall will actually expand outward at the same time that the lung collapses inward. And air will rush into this intrapleural space. Now, the only way that this problem can be rectified is to actually surgically insert a tube into the intrapleural space, suck out the air, and then try to seal up the wound. But again, this is what we call a pneumothorax. So we're going to look at what we call the mechanics of breathing. That is, what are the mechanical forces? For those of you that have had physics, this is very much like Newtonian mechanics. Now, what are the physical processes that cause air to move into and out of the lung? Well, of course, air moves in and out of the lung due to pressure gradients. And we've already talked about those. As the chest wall expands, it creates a more negative interpleural pressure, which creates a reduction in alveolar pressure. And as alveolar pressure reduces below atmospheric pressure, air flows in. When we stop expanding the chest wall, this allows the inward elastic recoil of the lungs to express itself, increasing alveolar pressure and exhaling or expiring air from the lungs. So the mechanics of breathing describes the mechanisms for creating these pressure gradients. So the forces that affect airflow. Well, flow equals the difference between atmospheric and alveolar pressure divided by resistance. This is very similar to what we saw when we looked at the cardiovascular system. It's basically the same equation. Flow equals a pressure difference over a resistance. So the force for the airflow is the pressure gradient. That is the difference between atmospheric and alveolar pressure. Atmospheric pressure is, of course, constant, at least constant during the breathing cycle. Obviously, if you change elevation, you're changing it, but you're not going to be changing elevation drastically during the course of a single breath. So the changes in alveolar pressure are the ones that create the pressure gradient, since atmospheric pressure remains constant. Alveolar pressure is going to change as the chest wall expands or ceases to expand. So the forces that affect airflow are described by what's called Boyle's law. Boyle was a physicist, and he says that pressure is inversely related to volume. So another way of expressing Boyle's law is that the initial pressure and volume relationship, and that is multiplying pressure times volume, if one of these two changes, if pressure changes, then the volume is going to have to change. So if pressure goes down, volume has to go up, and vice versa. So we change alveolar pressure by changing its volume. So as the chest wall expands, it pulls the alveolar walls outward, which of course is changing the alveolar volume, creating a smaller alveolar pressure, presumably during the beginning of inspiration, of course, making it become negative. And of course, resistance is the resistance to airflow, just as we studied in the cardiovascular system. And as we studied in the cardiovascular system, resistance is related to the radius of the tube, in this case the airways, as well as the presence of mucus, which of course takes up physical space within the airways. So as radius goes down, resistance goes up. And in fact, it goes up to the fourth power. So a very, very small change in radius, basically. Radius to the fourth power proportional to resistance. So a very, very small change in radius is going to produce a very, very large change in resistance. Let's look at the determinants of the intraalveolar pressure. Well, the quantity of air in the alveoli, of course, the alveolar volume. The alveolar volume. As the lungs expand, which happens during inspiration, as the chest wall expands, it pulls on the intrapleural space, creating a more negative intrapleural pressure, which of course pulls the alveolar walls out, or the lung wall, I should say, but that stretches the alveolar walls, ultimately increasing the volume of the alveoli so that the alveolar pressure decreases. This, of course, creates a pressure gradient. If alveolar pressure decreases and atmospheric pressure stays the same, then we're establishing a pressure gradient, which is going to drive air into the lungs. So this is inspiration. Then during expiration, the lungs recoil. Alveolar volume decreases. We cease expanding the chest wall, so we stop making the intrapleural pressure more negative, which reduces the outward pull on the alveolar wall. So the alveolar pressure actually increases because we now have this elastic recoil that we talked about before expressing itself. Think again of a balloon. What happens when a balloon stops expanding? As long as the opening of the balloon is open, the elastic recoil in the balloon expels air. So this is the recoil we're referring to. In this case, because of this increase in alveolar pressure due to the inward elastic recoil of the alveoli, pressure gradient is going to drive air out of the lungs. So let's take a look at how these pressures relate to volumes. So what we're plotting here is intraalveolar pressure versus the breath volume. Another term we will use subsequently is tidal volume. But that's the amount of air that moves in and out of the lungs during a breath. So if we move from this volume to an expanded volume, the alveoli are now expanding outward, we of course reduce alveolar pressure. So we're pulling in molecules of gas here. That's what these dots are representing. So we've reduced the pressure in the alveolus, which is going to bring air into the alveoli. And we keep expanding the alveolus to a certain point at the end of inspiration. Well, of course, as more and more air is moving in, as we approach our completion of the expansion of the lungs, the pressure is actually going to stop decreasing the alveolus and start going back up. It's still below zero, but we have more and more molecules moving in, filling up this increased space. So the volume is going to start tapering off because the driving pressure is actually decreasing at this point. And the opposite happens during expiration. We now have the inward recoil of the alveolus, bringing the alveolar pressure up. So, of course, it's going to be ejecting air, blowing air out of the lung. And this is going to, of course, decrease as the elastic recoil approaches its limit and the lung stops. I don't want to say contracting, that's just an active process, but the lung stops experiencing its elastic recoil. So let's take a look at the muscles of respiration. Inspiratory muscles, of course, increase the volume of the thoracic cavity. They have to, because inspiration is when alveolar pressure decreases, and that, of course, according to Boyle's law, if the pressure decreases, then the volume has to increase, and vice versa. So we have the diaphragm and the external intercostals. If you think about it, the external intercostals are on the outside of the chest, and they expand outwards. So in order to be an inspiratory muscle, they would have to be on the external aspect of the chest wall. Expiratory muscles, of course, decrease the volume of the thoracic cavity. These include the internal intercostals and the abdominal muscles. Now, it's important to realize that during normal quiet breathing, expiration is generally passive, meaning that there's no muscles required. So, during normal quiet breathing, as for example, as you're sitting here listening to this lecture rather than out running or something, you have activation of inspiratory muscles causing inspiration. And even though the external intercostals are listed here, during normal quiet breathing, the diaphragm is thought to be the exclusive inspiratory muscle, and the external intercostals only become activated when you start increasing your respiratory effort, such as during exercise. So during normal quiet breathing, it's generally the diaphragm contracting, it's bringing air into the lungs, and then expiration due to elastic recoil. So expiration is actually a passive mechanism, because it's just the elastic recoil that was the energy that was stored up in stretching the alveoli out expresses itself by recoiling inward, driving air out of the lungs. So let's take a look at this flow chart here in terms of what's causing breathing. So we have motor neurons. Now there are motor neurons up in the brainstem that are actually driving an excitatory input down to the true motor neurons that are in the cervical spinal cord. So these motor neurons in the cervical spinal cord innervate the inspiratory muscles in terms of the diaphragm. There are other motor neurons that are located in the thoracic spinal cord that innervate the intercostals. But this neural input causes the inspiratory muscles to contract, which expands the chest wall. By expanding the volume, remember that means, according to Boyle's law, that we are decreasing the pressure. So this causes interpleural pressure to become more negative because we are pulling outward on the chest wall. And this decrease of interpleural pressure, of course, stretches the chest wall outward, which is going to increase the volume of the alveoli. By increasing the volume of the alveoli, again, same thing we saw up here, we are decreasing the alveolar pressure. And it's bringing the alveolar pressure down below atmospheric pressure, and therefore increasing flow of air into the alveoli, which of course then is going to be bringing alveolar pressure back up. And this is the negative feedback loop that's shown here. As alveolar pressure increases, of course it's decreasing the pressure gradient for flow. So let's take a look a little bit more detail at these volume and pressure changes. This is a similar diagram that we saw in a couple of other slides. As the alveoli expand, we cause the pressure change within the alveolus to go down. This is alveolar pressure shown here. This is intrapleural pressure shown here. So as the chest wall expands, so chest wall is expanding, this is decreasing both the alveolar and the intrapleural pressure, which of course is bringing air into the lungs. But in order to keep decreasing alveolar pressure, the intrapleural pressure has to continue to decrease. And in fact, it will continue to decrease all the way to the end of the inspiratory effort. Again, the reason that the alveolar pressure stops decreasing here is that more and more molecules of air are now moving into the alveolus, and of course helping to stop this decline in alveolar pressure. So alveolar pressure actually starting to increase because we have more gas molecules in here bumping around into each other, which of course is helping to contribute to this increase in pressure. Expiration is the opposite. As we've seen before, alveolar pressure goes up. We stop this outward pull. So now we have an inward recoil of the alveolar wall. So we reduce this outward pull on the chest wall, bringing intrapleural pressure back up. It's of course still staying negative because it's under normal conditions always negative. The only way it would ever go positive is an extreme expiratory effort. And just as we saw before, of course, as more and more during inspiration, the opposite happening here is more and more molecules of air are leaving the alveolus. Alveolar pressure is starting to decrease, even though intrapleural pressure is not changing its direction. Excuse me. So as I said on a previous slide, expiration is normally a passive process. When the inspiratory muscles stop contracting, there is a recoil of the lungs and the chest wall to their original position, which means, of course, that we have, if this is the chest wall out here and this is the lung, we stop pulling out on both, which means now we have an inward recoil, this inward recoil here, of both the lung and chest wall, bringing them back to their original positions, bringing back the volume to its original value before we expanded the lungs. Active expiration requires expiratory muscles. So during exercise or any other event in which there is increased respiratory effort, for example, if you have a really severe respiratory infection, a cold or something, you have to breathe harder. So you, in fact, probably do engage in some minor form of active expiration, because having some sort of a respiratory infection means you're diminishing exchange of oxygen from your inspired air to the blood because of mucus in the lungs, etc. So you're engaging in a greater respiratory effort or ventilatory effort, trying to move more gas into and out of the blood. So you're going to need an active expiration to try to decrease the alveolar volume even more so that you can increase it more during the next inspiration. And of course, active expiration involves contraction of expiratory muscles. That's going to create greater and faster decrease in the volume of the thoracic cavity, and therefore in the alveolar volume. So the two factors that affect pulmonary ventilation are compliance and resistance. We've already talked about these to a certain degree in the cardiovascular system. We certainly discussed resistance. And just as resistance in the cardiovascular system occurs in the tubing that is in the blood vessels, same thing in the pulmonary system, it is in the airway. Whereas compliance is a process of the alveoli, that it is the ease or the elasticity, the compliance, the ease with which the alveolar wall can stretch that is related to what we call lung compliance. So we'll look at each of these. So compliance is the ease with which the lungs can be stretched. It is calculated this way: compliance equals a change in volume divided by a change in pressure. And if you think about it, when something is very compliant, it's going to take a very small change in pressure to produce a large change in volume. As an example, if you purchase a brand new balloon, it's very difficult to blow it up because it has very low compliance. But then if you stretch the balloon several times and really stretch it hard, then you go to blow it up, it blows up more easily. What you've done is you've increased the compliance of the balloon. You've made it so that a very small change in pressure can produce a large change in volume. Whereas initially, when it had low compliance, it took a very large change in pressure to produce a very small change in volume. So if lung compliance is larger, it's easier to inspire, meaning a smaller change in transpulmonary pressure is needed to bring the alveoli to a given volume of air. The factors that affect compliance, well, the elasticity, and in fact, the two are inversely related. If tissue is more elastic, think about it, if it's more elastic, it means it has more recoil. Therefore, it's going to require more pressure to get it to stretch. So greater elasticity goes along with lower compliance. So when we talk about elastic recoil, if elastic recoil is increased, then compliance is decreased, and vice versa. Surface tension of the lungs. Well, the surface tension is due to water. Basically, whenever water encounters a gas mixture, such as the meniscus of water in just a glass of water, that there's a certain amount of surface tension there. That's why there are these little insects called water skimmers that can walk on the surface of water, because it has a certain amount of what we call surface tension. And because the alveoli of the lungs are lined with a very thin layer of water molecules, this means that there is surface tension in the lungs. And the greater the surface tension, the lower the compliance. If you want to think about it this way, it's just not too far-fetched, is the idea that the water creates a certain amount of elasticity. And that, of course, means that it's decreasing compliance. So as I said, there's a thin layer of fluid lining the alveoli, which is largely consist of water. But there is also other factors that we'll talk about in a moment called surfactant. So when you have water, there is surface tension due to the attraction between the water molecules. So if this is, let's say, the surface of water in a glass of water here, and we have our molecules of water, these molecules actually attract each other. And that's what causes the surface tension, meaning if there's some sort of a force applied downward, that these molecules, because they are attracted to each other, actually help to repel any distension of this surface, or as standpoint, a deflection of the surface from its original position. So the surface tension is a force trying to make the alveoli collapse or to resist expansion, and this is, of course, due to water molecules. So there's a substance called pulmonary surfactant that's secreted by type 2 alveolar cells. We've talked about them earlier on in this lecture. And surfactant basically is a detergent, just like dishwashing detergent. Detergents decrease surface tension. That's how soap works. It decreases the surface tension among the molecules that make up the soiling on clothing or dishes or whatever. And pulmonary surfactant does the same thing. It decreases surface tension. And by decreasing surface tension, it increases lung compliance, which makes it easier to inflate the lungs. Airway resistance. The ability to get air into and out of the lungs is, of course, largely dependent upon lung compliance, but also, of course, upon airway resistance, because the air can't get into or out of the alveoli without going through the airways. So as airways get smaller in diameter, they increase in number, keeping overall resistance low. And in fact, as you get down to the smaller airways, you get to even lower resistance than you do in the larger airways because of this division. Resistance refers to the pressure gradient needed for air to flow. And it's quite low. It's only about 1 millimeter of mercury that is normally needed. And an increase in resistance makes it harder to breathe, just as we saw in the cardiovascular system. An increase in resistance impeded blood flow. Well, of course, it impedes or resists airflow. So if resistance goes up, then we're going to need a greater pressure gradient. So the pressure gradient is going to have to go up. So what we're looking at here again is our intra-alveolar pressure and tidal volume changes. And I'm going to switch colors since we have blue lines. If this is our normal curve in terms of intrapleural pressure, intra-alveolar pressure necessary to produce this change in lung volume. When resistance is increased, as shown here, it's going to mean that we need an even larger change in pressure. Now you could say this is becoming more negative, but this is 2 millimeters of mercury versus 1 millimeter of mercury necessary to produce this change in a bigger magnitude, that is 2 millimeters of mercury change in pressure to produce the same change in volume. It's negative because we're expanding the alveoli, which of course is decreasing the pressure, but it's still 2 millimeters of pressure just directed outward. So greater resistance means we need to create a more negative alveolar pressure to move air into the lungs, but we also need to create a more positive alveolar pressure to move air out of the lungs. Now, asthma is a disease in which resistance is increased. So resistance goes up in asthma. So patients with asthma, rather than having this normal curve we see here, would actually have to create greater respiratory effort to produce these larger pressure changes in order to move the same quantity of air as a patient without asthma. Let's take a look at some of the factors that affect airway resistance. Passive forces, that is changes in transpulmonary pressure during the respiratory cycle. This is, of course, an inspiration, transpulmonary pressure, or the pressure across the alveolar wall increases, causing the airways to expand. So as the alveoli expand outward, they tug on nearby airways and help to stretch them open. We refer to these as tractive forces. It might be easier to think of it as tractor, just like a farm tractor. But the idea is the root word there, the tract part meaning that it pulls. So these tractive forces help to pull the airways open. So during inspiration, as the alveolar tissue moves away from the airways, that is, the alveoli are expanding, they pull the airways open. So, of course, it's passive because it is due to factors outside the airways themselves. There are active forces, that is contractile activity of smooth muscle in the airways itself, as well as mucus secretion. As mucus is secreted into the airways, if it takes up more physical volume, if you think about this as being the normal cross-section of an airway, and then you put a layer of mucus in here, of course, it takes up a physical amount of space and decreases the diameter of the airway. So the smooth muscle in the bronchioles, in all of the airways, but we generally refer to it as the bronchiolar smooth muscle because it is down in the bronchioles right before we get to the alveoli where most of the smooth muscle changes can occur. Just as we saw in our terminology in the cardiovascular system, we have similar terminology here. Bronchoconstriction is when the smooth muscle in the airways contracts, causing the radius to decrease. Bronchodilation, smooth muscle in the airways relaxes, causing the radius to increase. And the contractile state of the smooth muscle is under extrinsic and intrinsic controls. So we have the autonomic nervous system, as well as local factors. One of the things we'll see there is that oxygen actually is going to have an effect on the smooth muscle tone. So extrinsic effects, the autonomic nervous system, as I said, the sympathetic nervous system relaxes airway smooth muscle. We talked about adrenergic receptors back in the cardiovascular system, and I mentioned that beta-2 adrenergic receptors cause smooth muscle to relax. So epinephrine primarily, acting through beta 2 receptors, is going to cause bronchodilation. Now I'm saying epinephrine because studies have shown there is actually very little, if any, sympathetic postganglionic axons within the airway smooth muscle. So, but it is known that activation of the sympathetic nervous system can cause bronchodilation, so it's believed that this is due to epinephrine. Parasympathetic nervous system causes contraction of the airway smooth muscle and therefore bronchoconstriction. This is due to acetylcholine, which of course is a neurotransmitter of the parasympathetic postganglionics, and this is due to muscarinic receptors. So as we've seen in the autonomic nervous system before, we have opposing influences by the two branches of the autonomic nervous system on the effector organs. Hormonal control, epinephrine, which I've mentioned before, causes relaxation of smooth muscle, bronchodilation. This, of course, is the transmitter from the sympathetic nervous system. Intrinsic controls, well, histamine, we've talked about its involvement in terms of the immune system. Histamine causes bronchoconstriction. Sometimes when people have asthmatic, so-called asthmatic attacks that are due to allergies, let's say allergies to pets, to cats specifically. This is why, is that the allergic response is causing enormous release of histamine, and the histamine is causing bronchoconstriction, which is what's inducing their asthmatic attack. So histamine is released during asthma attacks as well as allergic reactions. These are quite often linked. Histamine also increases mucus secretion. So, of course, that takes up more physical space within the airway, even without causing bronchoconstriction, but you do have these two factors, the mucus secretion and active constriction of the airway smooth muscle. So histamine causes particularly severe decreases in flow. And then carbon dioxide. As carbon dioxide level in the blood, if it should increase, it causes bronchodilation, which makes sense. If carbon dioxide level increases, it means that you need to increase the gas exchange in the lung, and causing bronchodilation will make it easier to get more air into the alveoli sooner and with less effort. So we'll talk a little bit about pathological states that affect airway resistance. I've already mentioned asthma. Asthma is caused by spastic contraction, that is, irregular waves of muscle contraction of the smooth muscle. Asthma is largely an inflammatory condition. So inflammatory mediators such as histamine, of course, are going to help cause some of these spastic contractions. There are other inflammatory substances that can also cause even greater contraction of the smooth muscle, buildup of mucus, and such. So the treatment of asthma nowadays involves using anti-inflammatory agents as a way of helping to reduce the inflammation that's causing the problem. Another type of pathological state is what's called chronic obstructive pulmonary diseases, and this is abbreviated COPD. Classic example there is emphysema. And in emphysema, the airways collapse more readily. So in asthma, they actually constrict. So it's an active constriction, generally. And in emphysema, it's actually more of a passive collapse of the airways. But nevertheless, it actually impedes airflow. And that's why it's called an obstructive disease, because it's obstructing airflow. So we're going to take a look at the clinical significance of the different pulmonary volumes, which we haven't introduced yet, and airflows. So we're going to be talking about lung volumes and capacities, and some pulmonary function tests, and how it relates to alveolar ventilation, which really is the most important part of all this. The total amount of air moving into and out of the lungs, in part, includes air that's just moving into the airways, but some of it never actually gets all the way to the alveoli. So what we're really interested in is how much ventilation occurs within the alveoli themselves. So we measure lung volumes and capacities with the process called spirometry. These days, of course, it's done with computers, but this is an old-fashioned spirometer, and I think looking at it helps you to understand how it works. I have a have a patient hooked up to a breathing apparatus that looks like this, and this is a spirometer. Technically, it's a bell spirometer. This structure here is referred to as a bell because it has a roughly bell shape to it. So this apparatus consists of two cylinders. There's this one that contains air, and another one is slightly larger diameter that's suspended over it that contains air. These are placed in a water bath, so this is all water that's surrounding it. And what the water is doing is basically making a seal between the surfaces of these two cylinders or bells. And the upper bell is suspended by this string on a pulley, which is attached to a pen. So as it moves up and down, the pen moves up and down. And of course, this bell moves up and down as lung volume increases and decreases during breathing. So what we see here is a pen tracing showing changes in lung volume as an individual breathes. So let's take a look at what we can measure with spirometry. So this tracing here is typical of what you would pull off this chart paper. The normal breathing that you engage in moment to moment is shown here as this small deflection. This is what we call the tidal volume. And if you think about the name tidal volume, refers to the tidal movement in the ocean as the tide moves in and out with regular frequency. Well, air moves in and out with regular frequency, hence the name tidal volume. So tidal volume is the amount of air that you breathe in and out during a normal breath. And again, it's difficult to read the writing on this chart. I recommend that you go to your textbook and look along for the details. If an individual is instructed then at the end, so this is inspiration here and this is expiration down here, they're instructed at the end of an expiration to then inhale as deeply as they can. You would have this part of the curve here. And this is referred to as the inspiratory reserve volume, or the IRV. The idea, the name is that, first of all, inspiratory volume. It's called a reserve volume because this is a reserve that you have available to you, a greater amount of air that you could inflate your lungs with if you need to. And of course, this is going to happen in exercise. Now, as you're getting ready for exercise, you're just breathing in your normal tidal volume. But as soon as you start running, or bicycling or swimming, whatever type of exercise you're engaged in, of course, you're going to have to breathe more. Now, let's forget about swimming since we don't want people inhaling water, so let's stick with something like bicycling or running. So a person is going to have to inhale a larger volume of air to get more oxygen into their blood to get down there to the exercising muscles. So the tidal volume is actually going to increase upward into what we call this inspiratory reserve volume. Similarly, there is an expiratory reserve volume. If you have a patient or a subject finish their inhalation, so they've reached inspiration here, and then we say exhale as forcefully as you can and hold it for as long as you can, this is now a greater level of expiration than what we saw normally. And this is called the expiratory reserve volume. Those two together, inspiratory reserve volume and expiratory reserve volume, make up this curve here, which is called the vital capacity. Now, a volume is a measure of volume change that is unitary. That is, it is something unto itself, a tidal volume, inspiratory reserve volume, etc. Capacities are the sums of two or more volumes. So the vital capacity is the sum of the tidal volume, the inspiratory reserve volume, and the expiratory reserve volume. And that's a little hard to read here, but it's shown here that VC, vital capacity, equals tidal volume plus IRV plus ERV. The total of all of these values, which is not well shown in this diagram, is called the total lung capacity. But the total lung capacity, and one reason it's not well shown here, is that when you're engaged in a forced expiration, you cannot blow out all the air in the lungs. If you notice here, there's still about 1,200 milliliters of air left in the lung. This is called the residual volume. The total lung capacity equals the vital capacity plus the residual volume. Another way of writing it, of course, is that the total lung capacity equals tidal volume plus expiratory reserve volume plus inspiratory reserve volume plus residual volume. There's two different ways of thinking about it, but of course they're both equally valid. This residual volume cannot be measured directly because there's no way of getting somebody to blow all the air out of the lungs. It's physically impossible to do so because, again, it is this functional attachment in the pleural space of the surface of the lung, the external surface of the lung, and the internal surface of the cell wall that is stretching the lung open. So it is that interaction of the two surfaces that is keeping the lungs from fully collapsing and why we have this residual volume. Now, in terms of what you need to know about this, you need to know what these volumes are in terms of functionally. I'm not concerned that you know the normal values that are shown here because these values depend upon the gender of the individual, their physical size, their height particularly, and their age. So there is no one normal value. Values vary depending upon the details of the person. So let's take a look at pulmonary diseases. We've talked about them a little bit before. We talked about obstructive disease. And in talking about the chronic pulmonary obstructive disease, that is one type of obstructive disease. Asthma also is. So both emphysema and asthma that I've referred to before are considered obstructive diseases. Restrictive diseases are when there's a limitation on alveolar volume. That is, it's difficult to expand the lungs. And this is due to the fact that the lung has low compliance, whether or not it's because of a large amount of scar tissue or other types of problems. Only about 5 to 10% of pulmonary diseases are restrictive diseases, and these are a problem where compliance is very, very low. So you're very unlikely to see very many of these types of diseases when you get into your clinical profession. Total lung capacity decreases in these, as does vital capacity. Basically, the lungs act as though they were stiff. Obstructive diseases, we're obstructing or limiting airflow. So obstructive diseases are associated with increased airway resistance. In this case, residual volume is going to increase. It's harder to expire. So go back to our spirometry measurements. If we've increased resistance, it's going to be harder for somebody to blow out as much air. So they're going to have a higher residual volume. And functional residual capacity increases. I haven't mentioned that yet. Let's go back to this. Functional residual capacity is this quantity right here. It is the sum of the expiratory reserve volume and the residual volume. It is an important value as well as a concept because this is the normal resting point of the system when it's fully relaxed. That is, there's no inspiratory muscle activity, no expiratory muscle activity. You have the inward recoil of the lung that is equal in magnitude but opposite in direction to the outward recoil of the chest wall. And it is a point of a dynamic equilibrium. And of course, physiologists love dynamic equilibriums. So the functional residual capacity, of course, is going to increase if residual volume increases. So as you said here, functional residual capacity increases just as residual volume increases. And generally, total lung capacity increases as well. Now, some of this is because some of the air that's in the lungs gets trapped as it's difficult to expire, but also generally, especially in emphysema, you actually have a physical loss of some of the alveolar wall. So, of course, if you have a loss of tissue, you have an increase in total volume. So some of the increase in total lung capacity is due to this tissue loss, allowing a greater total volume within the system. Let's take a look at some of the pulmonary function tests. It's called a forced vital capacity, or regularly in clinics just referred to as an FVC. It's the maximum volume of air that you can inhale, followed by exhaling as fast and as hard as possible. Go back to our spirometry measurements. Basically, it is forcing the person to engage in a single respiratory maneuver, a single vital capacity. And this is why it is called a forced vital capacity. Go back to our spirometry measurements, that might be more typical in terms of somebody breathing at vital capacity if they're out running. Each and every tidal volume now has increased to be the point where it is actually at the vital capacity if somebody's running at a very intense level. But to have somebody to stand in a laboratory setting and for one breath inhale and then exhale at their maximal level, so we again call it the forced vital capacity. A low FVC indicates restrictive pulmonary disease. It makes sense. If restrictive disease is a limitation of pulmonary volume, then vital capacity would be lower. Another pulmonary function test is called the forced expiratory volume, or FEV1. And there are different subsets of FEV measurements. We'll talk about those in a minute. But the percentage of the forced vital capacity that can be exhaled within a certain time frame is what we're looking at with our forced expired volume. The most frequently used one is the FEV1, which is the amount of FVC that can be exhaled within 1 second. The normal value for this is about 80%, and that is because 80% of the air that is exhaled is due to the elastic recoil of the lung. And that expresses itself in 1 second. So actually, the ability to force more air out is going to take longer than 1 second before you can get the muscles to contract sufficiently to augment that amount of volume. So this is a very good measurement of elastic recoil of the lung. If FVC equals 4,000 mils, you should be able to expire 3,200 mils in 1 second. So that's one way of looking at this 80%. When the FEV1 drops below 80%, it indicates an obstructive pulmonary disease. Generally, it's not exactly 80%. The threshold value that's used is about 65%. So if it's equal to or less than 65%, then we call it an obstructive disease. When it's greater than 85%, oops, let me rewrite that, greater than 85%, it's a restrictive disease. Another measurement we haven't talked about yet is what's called minute ventilation. And it's the amount of air that can be moved into the lung in a period of 1 minute. So it's the total volume of air entering and leaving the respiratory system during a minute. So it's the tidal volume times the respiratory rate. So if you have a normal respiratory rate of about 12 breaths per minute, a normal tidal volume of about 500 mils, the normal minute ventilation is about 6,000 mils. Now, this is the total amount of air entering and leaving the lung during a minute. If you think about it, there's a certain amount of this air that's being inhaled that's staying within the airway, staying within the conducting zone. So this refers to anatomical dead space. Dead space generally means, at least in respiratory physiology, space or volume that does not participate in gas exchange. And this is dead space for anatomical reasons. So if we start at our normal resting point at the end of an expiration, we have a certain amount of fresh air. This is, of course, environmental air in the airways, plus some old air. Now this old air is air that was in the alveolus during the last respiratory cycle. And when you exhale, there's still, of course, always some air left in the lungs. Remember, even if you forcefully exhale, there's always a certain amount of air left in the lungs. So this old air is air that is low in oxygen and high in CO2. And as soon as you start to inspire, this old air is the first air into the alveolus. And of course, it's followed by more fresh air coming in from the atmosphere. So the total amount of air, the fresh air that is high oxygen, low CO2 air that's inspired, is less than it could be because of this amount of air that's trapped in the airways. And this is, again, what we refer to as anatomical dead space. So the air in the conducting zone does not participate in the gas exchange. This air that's sitting here in the bronchioles is not actually helping to oxygenate the blood. So the conducting zone is the anatomical dead space. And for each tidal volume, assuming that the tidal volume is 500 mils, about 1/3 of that, or 150 mils, is dead space. So this is related to the idea of alveolar ventilation, in that alveolar ventilation is less than minute ventilation because of the anatomical dead space. So the volume of air reaching the gas exchange areas, that is the alveoli, in 1 minute is less than minute ventilation because of the anatomical dead space. So we have our minute ventilation here minus the dead space ventilation times respiratory rate. Well, the dead space ventilation, we said, is about 150 milliliters per breath. So we have our minute ventilation minus the dead space ventilation. And that will mean, of course, that assuming a tidal volume of about 500 mils, that the alveolar ventilation is only 350 mils.